Excellent. I think Maria's letting everyone in. And so with that, I just want to say good afternoon to everyone and welcome all of you to the last OC3R of this season before we begin our summer hiatus until September. Our discussion today is a topic that I suspect many intensive care units have hoped to implement, but was likely set back because of COVID. It is on early mobility of ICU patients, some of the how-tos and the challenges it entails. It is part of our commitment to discuss issues pertinent to critical care. As many of you are aware, Ontario Critical Care Clinical Practice Rounds, or OC3PR, is supported by Critical Care Services Ontario. It is a webinar series dedicated to helping all health professionals better improve the care they provide to critically ill patients by enhancing their skills and knowledge on topics related to critical care medicine. Our presentation today will be made available along with the previous webinars on both the CCSO website and their YouTube channel. Like previous presentations, we encourage you to submit questions to the individuals named Q&A for question and answer. Today's questions will be fielded by several members of the OC3PR committee, including Dr. Michael Sullivan. Again, we hope that you do your best to keep yourself muted for the discussion. I can remember when I started doing critical care that one of the orders that was written for all admissions was that of bed rest order for the activity A of the proverbial admitting order acronym DAVID. Now, granted, I did that in the last millennia. I suspect many centers still have this in their order sets. When we created our electronic order set here in Ottawa, I was adamant that our default would not be this, as my bias is bed rest is harmful. How can you get patients to be more active and mobile and maintain safety? That is a challenge that's not easy to overcome. Who you can safely mobilize is not always perfectly clear. How you mobilize most individuals is an even more challenging question to answer. As if those questions weren't difficult enough, how do you change the perspective of everyone involved and, better yet, find the resources to enact the changes? Well, that can become a downright daunting endeavor to solve. Thankfully, we have with us today some individuals who've been able to help address these challenges and will help share some of their secrets. We have with us Ms. Amber Robertson, who's a physical therapist at St. Michael's Hospital in Toronto, Ontario. She has worked in various units, including cardiology, thoracic and vascular surgical units, and now has over 5 years experience working in an ICU setting. She was a member of the Early Mobility Planning Committee at St. Mike's and is one of their physical therapists who help implement their program. She is joined by Ms. Ellen Lewis. Ms. Lewis is a nurse with over 30 years experience and has been an ICU manager for over a decade. She has managed the various ICUs at Unity Health St. Michael's site and is presently the manager of the Med-Surg ICU. She brings enthusiasm and passion on team functioning and aims to create a positive work environment for her teams. The objectives of today's webinar are several. We hope to explore the steps required to establish an early mobility protocol in an ICU, while also develop a better understanding of the importance of creating a cultural shift to enable the success of an early mobility protocol. Finally, we will consider the options to create a shift to a culture of early mobility. We would also like to highlight that CCSO has recently launched an early mobility toolkit, which will complement today's webinar. It is available at the CCSO website. Amber, Ellen, thank you both for taking the time to speak with us today. I will pass it over to you, Amber, who I believe will start the presentation, and I look forward to the discussion afterwards.
Thanks, Dave. We also included a link to that toolkit that Dave was mentioning in the presentation, so you'll see that later on in the presentation. So our early mobility project started around 2015. There was a lot of literature, and there continues to be a lot of literature supporting the safety and benefits of early mobility. but we were noticing some variability between the different ICUs in our center around how patients were being mobilized, who was doing a majority of that mobility, and general attitudes towards mobility. So here I've just listed a couple of the things that were pretty consistent in papers around the benefits of mobility at that time. So things like decreased length of stay, increased days off of the vent, decreased delirium, improved function. And I was going to put the papers from that time in our presentation, but when I was looking through the literature, there's actually so much new stuff since then that continues to sort of reinforce these messages that putting the papers from 2015 just didn't feel that relevant anymore. So the goals for our protocol in our center was, like I mentioned, to standardize a little bit unit to unit the different tools and to evaluate patient mobility using those tools. We also wanted to guide clinical decision-making for people who weren't necessarily physios. So we really wanted to put forward the idea that mobility is a group effort and that everybody can be mobilizing their patients. And then overall, our goal is, of course, to shift the culture, but that's kind of a side effect of all of these other things that we were doing, is that would be our end result. So what is early mobility? So before we started, we really wanted to have a clear agreement on what our goal was. And in order to do that, we had to sort of operationalize early mobility. From paper to paper, we were finding a lot of different definitions. It all kind of agreed that it was purposeful movement, but we really wanted it to be as close to kind of a SMART goal as possible to give us somewhere we were working towards. So we decided on active mobility within the first 24 to 48 hours. And again, that this could be initiated by any member of our healthcare team, not just necessarily the physios. So the very first step we took was we formed an interprofessional working group. So this had people like doctors, physios, occupational therapies, respiratory therapists, nurses, nurse educators. And we really wanted, it was important to us that it be multidisciplinary so that it's not coming from one person to another, that everyone was involved in the planning and implementation of this process. And then we assessed the current state of mobility in our hospital. So to do this, we took surveys, we took data, we did chart reviews, really trying to figure out, anecdotally, we knew that it was different unit to unit, but we really wanted to know where we were starting from so we could know where to go to. From that, we also did a literature review and used that review to create our protocol, and then piloted it and engaged it and rolled it out, which I'll get more into detail with as we go. So right off the bat, when we were doing our assessment of the current state of mobility in our hospital, there were a few challenges that came to light. One was that, like I said, the clinical practice was very inconsistent unit to unit of who was doing most mobility, when they were being mobilized, for how long, things like that. And there was gaps in knowledge about who is appropriate to mobilize, who is safe to mobilize, are the benefits really there? And then varying level clinician to clinician between how comfortable they were with moving their patients. So the first step in creating our culture of mobility in our unit was really educating to kind of address those challenges that we talked about. So that working group that I mentioned before created a standardized PowerPoint slideshow that sort of focused on all the research supporting that mobility was safe in all of these different populations. We also created a tool that I'll show you later that addressed exactly when patients should maybe not be moved and where that was coming from. The education of why it's important. So those things I mentioned before, decreased days off of the ventilator, decreased length of stay, decreased delirium, etc. And provided them with clear guidelines, tips, recommendations to really make people feel empowered to move people. One of the other things we identified when we did those staff surveys at the beginning was there was some concern amongst staff of, I want to mobilize my patients, but I'm worried that I already do so much work between boosting my patients and doing all of this that hurts my back, and I don't want to do more things that could potentially put me at risk. So we did some biomechanics education on how to safely move your patients for you. So this is that tool that I was talking about before. So this was put together through our literature review. There was one paper in particular, a 2014 paper by Carol Hodgson et al. Called Expert Consensus and Recommendations on Safety Criteria. Long name, but that's where we got a lot of this from, for the firm contraindications versus the precautions. Then after we did that literature review, we also took this to all of the medical directors of each of our ICUs for their review and feedback and comments. And then after that, we took it further to the knowledge translation committees at our hospital. So those are committees that sort of sit, again, an interprofessional team, and got their feedback on it. And after it had been approved through all those things, we provided it to our nurses and our bedside staff. We printed it on a sort of 8x5 paper and had it available at all of the workstations so that in real time, staff could be using this tool to see sort of the risk for mobilizing their patient. Is there anything that is instantly a red flag saying, no, maybe this isn't the right person to be mobilizing? And then on the flip side of that same paper that was sitting at the bedside, we gave them this kind of a tool. So this showed, based off of their level of alertness or their SAS score, so sedation agitation scale score, which is something that our nurses already collect hourly at our hospital. So it's not more work that way. It's something they're already assessing. Suggestions on some activities that may be appropriate for your person based off their level of alertness. So again, giving them more tools at the bedside to be like, okay, if I'm knowing I want to mobilize my people, what can I do? And then the occupational therapists also provided some information on activities of daily living that would be appropriate for these patients. And then, so with each activity, there was an assigned mobility score, with the idea being the higher the score, the more active somebody was, the lower the score, the less active. And you would assign these scores each time someone mobilized. And the benefit of this was it made it easy for us to track progress, because like we said, there was big differences unit to unit on how mobility was communicated even. So this gave us a standardized way between the different ICUs to track how effective this intervention was. And we talked to our nurses a lot about the idea that there's so much they're already doing to mobilize their patients. If you think of daily activities like getting up to the bathroom, getting up to the commode, by tracking it in this way, they're getting the credit for the work they're already doing. And then this was just another example of something we included in those education decks of sort of tips to progress the patients. And actually, this is also flagging me that I meant to say but forgot, that in those education decks, we did the standardized education that rolled out to all 4 units, but then we each had physios from those units come up with case scenarios that would be applicable to your patient population, and then use those in our education to help sort of have the nurses practice how to use this tool, how to use the risk assessment, things like that. And then this is an example of the education I was talking about around the biomechanics side of things. And with this education, we also did a hands-on session, again, practicing how you would do transfers in specific scenarios or sort of adverse scenarios that have happened sometimes in the hospital and how to deal with them appropriately without hurting yourself. So then after the education side of changing mobilities, we went to the engaging of staff side. So this is more around the rollout itself. We really wanted to generate buzz and make people enthusiastic about this idea. So to do that, we had unit champions. So this was mostly nurses, or we call them CAs, clinical assistants, PSWs, depending on where you work, who were sort of volunteering for this position, but also sometimes people who we just knew were strong proponents of the idea of mobility. So we sort of encouraged some people, but they sort of took on the education in their own unit They helped a lot with educating staff who were working night shifts, because that was one of the challenges we had, is how to capture those people. And then we also had a slogan contest, and we encouraged staff to submit drawings and slogans and things like that. And then the winning slogan you can see here. We put it on t-shirts, and then we use those t-shirts as some of the prizes in daily draws and things like that that we were doing. We all had other healthy prizes, things like Good Life gift cards or Booster Juice gift cards, things like that, to try and get people really engaging in this during the rollout period. And then while it was rolling out, we did bi-monthly audits and provided feedback at the time of our audits to kind of help people get more used to this tool. And again, to track how this was going. So this is the general timeline of our rollout. I won't go too into detail, but general idea is we rolled out the protocol in September, audited it from January to March, and then we noticed a little bit of a dip towards the spring in that following year. So we did a spring refresher to try and bring back some enthusiasm. During this refresher, we did daily audits now, and then tips for common errors. We posted up a lot of signs promoting it, and again, signs about the tips and common errors we were seeing. And we had staff nominate other staff members who they saw as having strong mobility or early mobility moments. We also changed our bedside flow sheet so that there was a place for mobility scores right in their flow sheet. And this, again, allowed us to track it really easily. It also made it easier to talk about it rounds with the doctors, because it was already what they were using to round with all the physicians. And it gave you sort of a real-time look at, okay, they got up at this time. How did their blood pressure, heart rate, medications, things like that react to that mobility? And it could allow people to really easily track that all in one place. We also made standing orders for physio and pretty much activity is tolerated in our ICU. Again, to make kind of the default that people should be mobilizing unless there's some real reason there's not appropriate to do so. And then the last thing we did was we standardized some transfer signs that I'll show you later. The idea with those was every time physio assessed someone, you would put up a sign on how they were mobilizing, and that would allow you to communicate with the whole team so that other people could also mobilize. And that sign followed them when they left the ICU and went to the floor. So again, keeping that strong communication between the different units. So this is an example of one of the signs that we used on our spring refresher. One of our physicians was kind enough to volunteer to be on this poster, but for today's sake, I put a happy face over his face. But again, showing that there was buy-in from other staff in the hospital. This is just showing, you can kind of see before the spring rollout, there was a little bit of inconsistency on how well people were doing with their mobility scores. There'd been a little bit of a dip in some units. And then after the refresher, that all of the units were now able to meet that 70% compliance target that we had set, and that they were hitting prior to the refresher, or prior to the dip, pardon me. And these are those transfer signs we were talking about. So again, in our ICU now, every patient who's been assessed by physio will have something like this up at their bedside, just to make sure that no matter who's in the room, everybody's kind of aware of how this person should be mobilized safely right now. And that's it for my section. I'm going to hand it over to Ellen.
Thanks, Amber. Great job. So now I wanted to just follow up with all this work that we did with early mobility, as Amber has spoken about. In 2019, then, we were approached by Critical Care Services Ontario to partner with them to develop and work on this provincial early rehabilitation in critical care project. So we partnered with CCSO, and the objective of the project was to really develop and test a protocol that could be incorporated early mobility as a standard of care in critical care. And then secondarily, provide a standardized early mobility guideline that then could be sort of spread and used throughout critical care units across Ontario. So this was, of course, we jumped at the chance to be involved in this project. And the perk, if you will, of PERCC was that the project really provided the organization with dollars that helped to increase our health human resources to really focus on continuing the early mobility and growing. It also provided some financial dollars to add additional equipment that was needed for early mobilization. So again, it didn't really change what we were doing. It just sort of augmented our previous existing work and just kept it going. So this just shows that prior to PERCC, the MedSurg ICU was a 24-bed unit, and we had just 2 hardworking physiotherapists in the unit for those 24 patients. There was no one extra with them. And the weekend, our patients would really get mobilization Monday to Friday with physio. They would get passed off on the weekend to nursing to try to continue some of the mobility moments. But because there was a weekend physiotherapist that covered, 5 other units, and the focus was really on patients that needed chest physio and not so much getting up in chair mobility. During PERCC, we grew to add an additional 1.5 physiotherapists, so for a total of 3.5 physios. But at that time, our beds also increased to 27 beds. We added an occupational therapist as part of this, rehabilitation in critical care. We'd never had an occupational therapist in MedSurg previous. So this was a welcome addition to the team. It did, the OT was able to focus on activities of daily living with patients, to patients that were suffering ICU delirium, provide different approaches to lessening delirium. So that was a really welcome addition. And also the PTA OTA. So a physio and occupational therapy assistant was hired for a 0.5. So they would come down in the morning and they would assist the physios with those patients that were, really heavy, that couldn't be mobilized with one therapist. They would assist to get the patient up and going. What it did was it really freed up nursing resources, because previously it would be the nurse often that would assist the physio. So this OTA PTA was able to jump in and assist with those. And then it gave us weekend coverage. So we had dedicated weekend physio for all of our patients in MedSurg ICU. And then we were able to continue all the great mobility work that was done through the week, continued onto the weekend. We did try to be a little creative at the beginning with trying to spread out the hours, because like I said, we went from 2 to now we have 3.5. But of course, in that 3.5, they needed to cover the weekends as well. But how do we try to spread it through the shift? Because typically the physios would work sort of 7:30 to 3:30. So we tried extended hours, but we really found that it was not as beneficial as we thought it would be. The patients were typically too fatigued for a second physio moment, a second mobility moment later in the day. And then because we only had the PTA, OTA half days, then it would become the RNs would need to help with the physio. It would be handover, it would be mealtime. There were just a lot of things that kind of got in the way that really wasn't using the resources efficiently. So we went back to the model of sort of a 7:30 to 3:30 with a little bit of stagger, but not so late in the day. In addition to the health human resources that we were able to increase with the PERCC dollars. We also had money for the equipment, like I said. So we bought a trilogy vent, so a vent that they could get patients that were ventilated up with for ease of mobility. We bought a sit-to-stand device and lots of additional OT equipment for patients to use. So this was at our site at St. Mike's, but at the same time, St. Joe's also were doing the PERCC project, and their resources, they went from 1 for 17 beds to a 2.0 with PERCC, and they went 12 hours. It also provided them with 7-day coverage. And they then were able to free up the physio on the weekends to cover the other units in the hospital. And they also added an additional role of a PTA, which they found really helpful. And they actually started as a 1.0, but decreased to a 0.5 is what suited their needs. And so then PERCC came to an end, and we knew that we couldn't go back to what we had previously. So not only, had we seen the benefit of the additional resources, the unit, as I said, had grown. We'd also split off into 2 separate locations, where we used to be in one big cozy location. We were in 2 completely separate units. So spreading 2 bodies across these areas and being able to continue just wasn't something that we thought we could go back to. So we put together a bit of a business case with showing the benefits that we had experienced with PERCC. We did staff surveys, we gathered some data, and we took it to our senior leadership, and we were very fortunate to be able to receive the additional health human resources into our budget that we had during PERCC. So we were all very thankful and happy to be able to continue with that. This just shows what's really quite obvious is the difference of the different mobility events, the total patients that can be seen. The dark purple is when our additional resources covering the weekends. And so previously, as I said, the weekends were really scarce and patients weren't mobilized the same. But now with a dedicated physio, every patient is up both days on the weekend. And this just demonstrates the usefulness of a PTA, OTA, and even for half days, the dark purple is what they do in a half day. The lighter is what they could do even in a full day. But we're very thankful again for the resources that we received for that. This next slide is just primary themes that came out during staff surveys, so 2019 and 2020 during PERCC. So the staff said that it was really easier to find assistance to mobilize a patient, where before they had, like I said, the 2 physios, and they were really stretched. So this was, everybody could get up with so much more ease. Patients were obviously being mobilized more. There was improved quality and safety of care. They felt that there was better communication and teamwork. And just having the combination of physio and occupational therapy was very beneficial to our patients. And it really did lessen the RN workload because physios and the OTA or the OT were mobilizing a lot of those patients that took 2 staff previously to get them up. So it really helped with RN workload as well. And then looking at the future of mobility in our unit, all the excellent work and energy that the various team members over the years have brought to early mobility, and really, as Amber spoke about, that changing culture, has been so well instilled into our unit and throughout critical care. And every new RN onboarding in critical care, Amber and her colleagues speak to the nursing staff that are onboarded to really continue that energy and philosophy of every patient gets out of bed. And the medical residents that are onboarded monthly also receive the same sort of pep talk. And the Amber and her colleagues assist with physio education throughout the hospital, talking about how to really change the culture in their own units for early mobility. We in MedSurg ICU are looking at a small VV ECMO program. We began education of nurses, but again, because mobility is so instilled in the unit, of course, the first question was, how do we mobilize these patients? What's that going to look like? So, the team never shies away from any patient you would think lying in a bed. It never ceases to amaze me, the patients that I see Amber and her colleagues getting up out of bed and out into the hallway. It's really impressive. We've just started to use the non-invasive, it's like a big helmet, looks like a big bubble helmet. And those patients as well are getting up out of the bed. During COVID, the patients were up in the room. There's nothing stopping our physios from, that's their job. They come in, everybody's out of bed. It's really quite impressive to see. And this is just a link to the toolkit that was developed with CCSO for other critical care units to utilize, and some of the things that Amber showed are within that toolkit. This is just one picture that we had of a patient, not too many. This guy is kind of a regular patient that would get up. Amber gets up, other patients, but this is who we had permission to share. But a very thankful patient that enjoys getting up in a high wheel walker and getting out for walks in our crowded hallways, but he gets up and gets moving. And that is the end of our presentation. Thank you for listening.
I think we'll have to use our imagination for the patient there, since I think in one of the many versions it might have gotten removed. And I'll give you an image for the helmet. We called them our minions when we put them in, like from the Despicable Me cartoon. So we called them our minions. So with that, before I go to Crystal for some of the first questions, I guess one of the questions I had for both of you is, I know during COVID, they were horrified that I would get patients out of bed, never mind start walking them around. So what do you do in terms of infection control precautions, and how does that impact your ability to mobilize? I obviously getting them to a chair by the bedside, that is not insurmountable, but are you able to walk your patients? What are your infection control? How do you address that issue to both of you?
Yeah, so at our center, while they're still in that first 2-week period where they're still on airborne precautions and things like that, we mostly mobilize them in the rooms. We've tried to set up the rooms as best we can so that we can walk laps for people who are able to do so, but obviously you're limited for space for that. We also started doing a lot more of the sit to stands or marching on the spot or things like that than we would normally do. Normally when we would be taking these people to the hallway, we just kind of had to get creative about ways to move within the room. But then when they're past that airborne and they're now just onto droplet contact, then we can walk them in the hallways just with a mask, and they can't be on any aerosol generating. So also prior to COVID, we would walk people in the hallways on OptiFlow or things like that. But obviously now we can't do that. So we've used a lot more of the non-rebreathers than we used to.
And I would presume those are the non-rebreathers with the filters as opposed to the others, just for clarity. So,
yes, I'm blanking on the name. It starts with a T, but I can't remember what it's called.
oh, since they're not sponsoring OC through PR, we won't give them the plug there, but the filter non-rebreather masks with it. I don't know the name either. So Crystal, I was wondering if you had a few questions for our speakers.
Yeah, for sure. That was a great presentation. Thanks so much, Amber and Ellen. One of the questions that came up, or a couple, what was in your early stages, what was one of your biggest barriers and how did you overcome it, whether you expected it or not? And the second part is what was one of your early surprises and positive either feedback or outcomes you noticed?
Yeah, I mentioned it a little during the presentation, but I think one of the barriers early on was that for the units that felt like they were already doing a lot of mobility, they kind of took this as well, this is other people's problems. This isn't our unit. In our unit, we mobilize well. So why do we have to do the scores? And so we really tried to frame it as, you're right, you are doing all of this work already, and that's amazing, but we can't track it right now. So by putting these scores down on a flow sheet that you're already filling out, you're now really getting some credit for this, and trying to show it as the scores were not being used to be like, well, did you or did you not? They were being used to communicate amongst people and being used to be able to track changes and see how people reacted to their mobility in a little bit more of a concrete way. I don't know if you can think of another one, Ellen.
No, I think that was a good one, because I think back to the staff surveys that I think I was surprised at. I remember one of the surveys, the responses of, yeah, like, we do this really well already, right? And like you said, yes, they do, but how did we get people on board with sort of standardizing the approach and creating a standard language that could be used at rounds across the team?
Perfect. And the other part was before we move on to Neill is what was an unexpected positive or positive feedback or opportunity early on?
I think generally people were like, it was positive. Like, I think with anything, you start out a project and people are excited about it. And you always have some that are a little slower to the gate. But I think for this, I think people were, happy to sort of quantify the work that they already did and how to just make gains with the work that they were already doing. I think it came across more positive than we initially thought it might.
Nice, thanks.
I think another small positive surprise, and it sounds very silly, but is one of our prizes were like pens that had our logo printed on it. And people really love pens. Like, everyone was willing to do the quizzes. Everyone was willing to participate if you could give them a pen.
Nice.
I would have done it for that happy face that you could put on. So never mind the shirt, but
we'll get you one.
That's good. I'm curious, before we go to Neill, do you use in-bed bikes? Like, we ordered one and we have one, but I was wondering, is that part of your early mobility program, and if so, how many do you have, or what's your thoughts on it?
Yeah, so we have one right now, but it's being used primarily for a research study that we're doing that's being run out of McMaster, but we're one of their test sites. But really, we don't use it very often beyond that. And the reason for that is the setup. It takes like upwards of 15 minutes just to get somebody situated for it. And then while you're there, you have to supervise them the whole time. So the session ends up taking 45 minutes to an hour. And for the benefit to the patients, we felt there was ways we could mobilize them better without that long setup period ahead of time.
Interesting. And I was also worried about how you clean it. That certainly would be an ongoing challenge. Neill, I was wondering if you had a few questions for our speakers.
Sure. Thanks very much for that talk. I wanted to ask about the PERCC program, and in particular whether it was still ongoing. Whether I might have missed, you might have mentioned this, but did that upstaffing continue after whenever it was? Because in the slide it sort of talked about end of 2019, so I was kind of wondering where you were after that.
Yeah, no, we were fortunate enough to be able to continue within our operating budget the resources that were put in during the PERCC project. We were able to speak to our senior leadership who supported having those continued resources.
Great. And I guess in follow-up to that, do you think that from all the work that you did, now going back a number of years, do you think that this has been like become embedded in the culture of the place, and it's sort of you're not resistance has melted away, so to speak, or and what's your do you think that is there anything really active that you're doing to have to maintain the success? Like the graphs were pretty impressive on the numbers of patients that were mobilized pre and post. Like I guess it was absolute number that you had there. Is there anything you're doing actively on the education side other than sort of orientation stuff for new staff and physician trainees and so on, or is it just sort of happening?
So I think like really the two big things that we do to keep it going are the new staff orientations. The staff orientation we do with the nurses, we go over that scale, we go over the contraindications and precautions and things like that. And then the orientation we do with the residents focuses a lot more on the idea of the benefits of standing orders, the benefits of avoiding bed rest orders unless it's absolutely required, things like that. And then I find the staff who were there for the early mobility project have now seen over the past few years that it has been successful, and that the risks or the things that they were concerned about, they see us mobilize so often now that those concerns aren't there. And then by orienting the new staff and then having the buy-in from the staff who were there from the project, the cycle just kind of keeps itself going.
Yeah.
That's good to hear, because you certainly don't want to be the only champion of it. So the fact that it's, can live on its own is certainly important. So I'm going to go back to Crystal in a few minutes. I just want to encourage our listeners to also do the survey that will be coming up. And Ellen, just a quick question, because I think one of the issues that people have is about staff injuries. And did you note any change in that, both for the better or for the worse because of this? Just because people will, like managers and directors would have that question for you.
Yeah, that's a very good question, and not one that we've actually quantified. But I would say that having, the sessions that physio provides, and that's another thing that we do with new staff coming in, is sort of ergonomic sessions, using the lifts for turning in bed, the limb holders, those kind of things. Sure, we have, musculoskeletal strains and injuries, but for the size of our unit, it's certainly not a lot, but I can't quantify if it's any different now versus a few years ago.
That's great. Not notably worse, I guess, is probably
no, exactly.
with that. So I'm going to go to Crystal, and then I'll go to Neill, and then we'll get some closing comments.
Thanks. A couple of questions that have come through. So I think maybe there was mention, they just wanted to confirm, so there's a standing PT order for every patient. So every patient is assessed by PT, just to confirm that, and any challenges with that?
Yeah, so there's standing physio orders. So we say essentially everybody is screened by physio at the very least. And then those who are appropriate are assessed. But in our unit especially, there's such high acuity that there's often quite a few people that are on medications that would prohibit it. But the idea is as soon as they're off of those medications, we're getting them mobilizing as soon as possible.
Perfect. And the second part to the question was, what type of patient and family feedback have you had through the rollout and experience?
We actually tried a survey, it was at the beginning, just at the cusp of COVID. We had worked with CCSO to develop a patient family survey to sort of understand what their feedback was. And unfortunately, it sort of got hijacked with COVID and families not being in. But certainly families, are ever appreciative of coming in and seeing, now that we have visitors back, coming in and seeing their loved one up in the chair and knowing the team, like they get to know Amber and her colleagues. And, if we have a complicated family, we'd have a, interprofessional family meeting where the physios would be present, interacting with the family. So I know the physio team really, if the family's there, they discuss with them and teach them exercises, for our longer stay patients, exercises that the family can continue on. They provide that education for, and I know that the families are very thankful for that.
Yeah, and just to add to that, I think too, the work that the Early Mobility Project of making the whole unit as on board for physio and mobility in general as they are has helped make the families feel more confident too, because the message isn't just coming from physio, it's coming from the doctors, it's coming from the nurses, it's kind of coming from everyone about how beneficial this is, which makes them feel a little bit more confident.
Nice, thank you.
Excellent. And we'll go to Neill for one last question, and then we'll do some closing comments there.
Sure, thanks. Question from the audience, from an RPN who's asking for suggestions on how to start the conversation on early mobilization. Sounds like this individual is working in a place where there's some mobility, but maybe not to the same degree or extent as is done in other hospitals. And how do you go about starting that? I guess particularly if you're not, if maybe you don't have all of the sort of language that physiotherapists would by background of profession.
I think the toolkit would be helpful. Using the CCSO toolkit would be a really helpful place to go to as a starting resource.
Yeah, the other thing I would recommend is that when I was looking for those old papers that we had used, there's been quite a few systematic reviews and meta-analysis of like the safety of mobility and early mobility and the benefits that have all come out in the past like 4 years. There's quite a few recent papers. So maybe having those with you as a like, look, the research supports what I'm saying.
Yeah, and the benefits and the safety. I think staff worry about the safety of their patient. They think, particularly in critical care, oh, the patient's too sick. They're on, they're on so many drips. There's so many lines and tubes, and it's just, I don't think it's safe for them to get out. So it's providing the explanation of safety and showing that it is actually safe and effective and beneficial for the patient. Over that feeling of it's okay.
Yeah, I think that's actually a super important insight to how to deal with the do no harm thing that we all sort of we all sort of take to work, and rightly so. And so that having, and that again, that reference to the toolkit, which it sounds like could be, and research, which I think which are powerful drivers. On the sort of specific issue, there's just one quick question. Someone has a question about, they phrase it as, how do you overcome resistance from specific surgical groups. I'm not sure which ones they were referring to in particular, but one thing is that one other specific question is about sutured femoral lines, and do you have specific policies on mobilization when you have femoral, arterial, or venous lines, and if so, is it up to a certain amount, so up to a certain size?
You got that, Amber?
Sorry, could you repeat the last little piece? It was arterial lines and something I missed.
Venous lines. Do you any specific policies on that, on those two access devices?
Yeah. So our hospital, like I follow their policies. So essentially they say that you can't kink if it's like a femoral line above 90. So I can still do a dangle. If somebody's only able to sit in 90, they could still potentially sit in a chair. Sometimes I'll recline it a little bit, but just trying to follow that guideline of not going any higher than 90. It makes it a little challenging if you wanted to stand somebody, because most people do flex beyond that when they stand up. But if you have enough help or the right angles, it's doable. But yeah, that's the main policy for our hospital.
Great, thank you.
That's great. And certainly we all look forward to seeing you present stuff on the ECMO patients, because nothing would make the argument that, yes, we can do our patients if you're doing it with ECMO patients. So if you can give me that material, I'll be forever grateful. So Ellen and Amber, thank you for taking the time for such an engaging and wonderful presentation and answering the questions with that. I just want to remind everyone about the survey, and certainly we should acknowledge this is going to be the last OC3R this season. Summer is finally coming, and I hope everyone will get to enjoy it this year. And although COVID is still around, I guess the mask mandate is coming off, and hopefully people will get out and be safe and have some much needed time. I just want to say thank you to the CCSO team. Certainly for putting this on, putting up with people like myself and others. So certainly appreciate that. I'm going to go to Dr. Lawless, who helps lead CCSO, before we get some closing comments from Dr. Mike Sullivan there. Bernard?
Thank you, Dr. Neilipovitz. Excellent job of chairing this session again, as always. And thank you to Ellen and Amber for their presentation. Really, you know, I was prompted, I guess, by, it may have been Neil's question on the ongoing sort of piece of this that we expected after this. This was initially supposed to be a bit of a pilot, and then we're hopefully we're going to be able to expand it. But that there's a number of things that probably got in the way of that. So, but I think even having the tools and having the discussions and having increased awareness around mobility of patients in the ICU is an added benefit. And so hopefully there's some things that people can take away from that, and in accessing the toolkit or having the conversations in their own critical care units. I want to thank our CCSO team who make this seem seamless and flawless in terms of the technical application for getting this out there and having it streamed on our YouTube. And I also want to thank our committee who do put quite a bit of effort and work into, you know, the selection of topics and the selection of speakers. This has become something I think that people have looked forward to and participated in quite strongly. And so it's become a venue that we can share information and current practices for critical care. And I particularly would like to thank Dr. Michael Sullivan, who I believe this is not just his last session, but he'll join, I'm sure, when they're on, but who's stepping down from the committee. And it's not without having put in yeoman's work on the work of this committee and the work of getting these presentations to all of you. And I always appreciate Mike's candor and his insight and his sense of humor. And so really appreciate all the effort and work you put into this. And we will miss you around the table, but we know you're not far away.
Bernard, that's very kind. Thank you so much. I just want to kind of jump in and say how much this team has contributed to this effort, in particular yourself and Crystal and Neil and Josée and Nancy and Maria, who've really pulled this thing together. I'm going to save my special thanks for Dave, who has been here as our front man every single time, and has really been the person that has had to each time make sure that everything came together. I mean, that was the most responsible person in this, and it's just been a privilege to be working along with Dave. It's been a great year for us. I think we've really started to move out to a diversity of topics. This one in particular, and Amber and Ellen, thanks so much for your presentation. This one in particular for me really kind of illustrates the interprofessional team, the fact that it's really important for us, and for those of you who are out there, we're delighted to be moving in a direction that's going to see more of our interprofessional team being a part of our planning committee as we move into the future, because we think that that's important, that our committee should be representative of what's going on. And I think that, the two pieces that I could really feel were coming out here in this particular presentation were leadership, in terms of just patient, steady, continuous, constant, always there leadership in order to achieve this, because really what we're talking about here is a culture change. I don't know if I could count up the number of things like this where there are things that we know we should do, and yet we can't find a way to, like, collectively in our units to be able to go ahead and accomplish them. And here's a group that's been able to do this, and I know is willing to be able to help. And then on top of that, we've got some support from CCSO to be able to support units to be able to make these kind of steps forward as well. So I think I think this is a terrific topic for us to end on this in this academic year. I wanted to say one more thing. I was just flipping through here in the screens, and I noticed that we're here. And to your point, Dave, about the fact that the mask mandate is coming off. Maybe one of the things we're going to encourage coming up here a little later is that people make themselves available on the screens. I don't think you're fooling anybody if you think that we don't know that you're working on your computer at the same time that you're listening to this. So you don't have to hide this fact from us. It just would be nice to be able to kind of see a few people as we go along. So maybe we'll make that part of continuing to build our community as well for next year. Hey, thanks for popping in there, Trish Vickers. It's been a real privilege for me to be a part of this whole thing. Hey, Kate Williams, thank you. Great to see you all jumping in. And really, really nice to be sharing some faces with people along the way. So we're gonna go ahead and continue to try and use this as a vehicle to build this community. When Neil and I started on this tiny project in between wave 1 and wave 2, the concept was that we were going to develop something that maybe we could use to bring the critical care community together. And I think, particularly with CCSO's help, we've been successful at that, and we're going to keep trying to figure out ways to do it even better. So I hope all of you have a terrific summer. We'll see you back on September 15th and start off another great season. See ya.